Right, thanks, Steve. Hello to everybody. Hey, that's good. um, right, today is the second part of the lower back. Um, we're dealing with radiculopathy today. Um, it's actually, although we're concerned with compression of the nerve roots and the terrible things which can come from there, and patients' beliefs about the terrible things, it's actually a very easy thing to actually just cover here. And there's not going to be an awful lot because when we use the laser, it's very simple. And we'll bring a bit of movement into when we're doing it. But we'll show you with the handset, handpiece, the wand, and we'll also use the Charlie head as well. Both, you can use both together. We can do what we want. This is the easiest bit of radiculopathy. I think the biggest problem we've got with radiculopathy is negative beliefs. And negative beliefs, not so much from the clinician, although clinicians do have a way of actually making these things sound very bad with all the language we use and around that. But a patient's negative beliefs about their low back pain leads to many things: fear of movement, depression, all sorts of stuff. And these, by all research has been shown, are incredibly predictive of disability related to the low back pain and ongoing problems. So very poor prognosis. There is, I will want to actually talk also about what I used to do with the military. And I think it's a very important thing, because we used to deal with so many of these radiculopathies, and you can imagine possibly why, because these people are doing such active jobs and getting an awful lot of these nerve root problems. And we would have these 3-week inpatient classes or courses where we used to have such miraculous changes for people in 3 weeks. Now, you can't do that in the civil world, but let's not worry too much about that. We'll come on to that in a minute. Let's just go through some the ACER slides which they've given me. So I'm going to share my screen. We'll go through that as quickly as we can because I think we need to talk more. Lower back pain 2, radiculopathy, treating with MLS Class 4 laser. Right. Common cause of radiculopathy, disc conditions. This is all stuff which we know: herniation or just a protrusion caused by compression, leading to trouble on the nerve root. You can also have things from spondylolysis. So I don't want to get into that stuff because I don't think that's the really important thing. The same treatment is going to be the same. Facet joint syndrome can cause some problems. Osteoarthritis, degeneration of the spine, which then can also lead to stenosis, which isn't on there, where you have the intervertebral foramen narrowing, where the nerve root goes through. All these things cause a radiculopathy, compression on that nerve root, okay? And you have very specific symptoms depending on what level is in trouble. And that's the stuff which is about clinical diagnosis. We've got to look at these people. If we work out very seriously what is the level which is involved, then we can go straight in, treat much more specifically with the MLS laser, which is going to reduce the inflammation, which is the big problem. You've got inflammation from the compression of that nerve root. That has become much thicker. The area is small because we've got, bad posture, all sorts of stuff. And it's just an ongoing problem. There's loads of medical treatments which can be done, stuff like your steroids, your epidurals. None of the research is very positive. The only time, certainly with surgical treatment on a radiculopathy, the only time that they've got good results back is on stenosis, where they can remount that intervertebral foramen. That is literally the only time we got any improvement. What is in the improving thing is the conservative treatment. And if we've got something like the laser to reduce the inflammation, then we're on a winner straight away. Just to let you know, I'm not sure how much you all know about this, but currently there's an orthopedic surgeon in the United States who's leading an FDA series of trials using the MLS laser on COVID-19 patients. While they're prone, it's been put over their back to actually reduce the inflammation in the lungs. Now, it's being used in two areas. One is in the area where they're actually in intensive care to try and stop them going onto ventilators, because the results with ventilators are not very good. And the other one is in the rehab afterwards, because they still have, you know, they recover from the COVID-19 virus, but they've still got massive inflammation in the lungs, so in the rehab as well. And there's a big trial going on at the moment, and we're awaiting the results on that. But it's all very interesting. Okay, that's stuff which we know. Things which you're going to see from a radiculopathy, depending what level it is your dermatomal pattern. Right, they've got a lovely dermatomal pattern up here. You can be very careful about these, because if you get 20 textbooks will probably have slightly different drawings of the dermatomal pattern. We've got to know roughly where we're talking about. So I don't know if you can see me, but I'd always go to the top of the thighs, 3, 4, 5 coming down, which roughly follows there, outside S1, outside of the foot. We'll get onto that later. Assessing pain in the lumbar spine. Right, general patient evaluation. Let's look at all sorts of things. Muscles, bones, specifically muscle strength, range of movement, hip position, iliac crest position, spinal alignment. It talks about muscle strength. That's the other thing which you really have to check for. Is not really actually the muscle strength, but it's myotomal strength. Because if the nerve root is being affected, then the motor impairment is noticeable. And that will give us also an exact spot of where the problem is. And we've got these little things. What I'm going to do is, right when we start treating the patient, but I know 80%, I think it is, of radicular lumbar problems is all between L4, 5, S1. And we'll just concentrate on those 3 very little areas. We'll just concentrate on that and show you some very easy way of checking out, so we know exactly where to put this laser. Okay. Disc conditions, right, all stuff we know. Normal disc, degenerative disc, bulging disc. You see it's coming out in that area into the intervertebral foramen. That can quite easily be putting pressure on the nerve root. Herniated disc, where big nucleus pulpus has popped out the back. That is putting massive pressure on the nerve root. This is where we start getting some real problems. We've got thinning disc degeneration. We're not actually concerned about that. We're talking about the radiculopathies. So the herniated disc and the bulging disc are the big ones for us at the moment. Okay. Disc conditions, herniation, protrusion, so many things. They've listed a few things here which cause problems: incorrect posture, mechanic alterations, muscle weakness, stiffness. Can be found, it's actually saying 9% here, can be found at any spine level, but most commonly L4, 5, L5, S1. 90%. I thought it was even less than that. Posterolateral lesions are the most. It's because people are bending forward and the bulge is always coming out the back, or it herniates out the back. Always be careful. Red flags are very important. If somebody's got bilateral radicular pain, are you going to treat them? No, you're not. You're going to send them straight down to A&E, because then most likely they'll also have saddle anesthesia, numbness in the groin. They'll also have urinary retention, and fecal incontinence. I mean, if they've got any of that, you don't want to be seeing them. Get out of here and get them down to A&E straight away. Symptoms: local pain at the spine level. You'll get a lot of muscle contraction, which we can use the trigger point settings on this laser as well. And what's this say? Dermatomeric. Basically, your dermatome pain and your myotomal weakness. Check these things. The other thing we have to check is reflexes. And that's going to be very important actually later, because I just want to show you something which very few people know about, but it's actually testing. See if it's how many L4, 5, and S1. How many of you know how to test the L5 reflex? And I bet it's very, very few of them. It's so simple. It's one thing which is overlooked, but basically reflex on the medial hamstring. We do that, and then we can actually really zone in onto exactly where the problem is. Age 30 to 50 years, that is really for a herniation. After, it doesn't mean you won't get radiculopathies, but after 50 years old, generally you're not going to get a herniation. And why is that? Because we all become old and decrepit. That nucleus pulpus, which is lovely toothpastey consistency, has dried out, and you're not going to get the herniation. That doesn't mean you can't get bulging discs or pressure into protrusion into that intervertebral foramen. Testing for sciatic pain. We all know this. We don't need to go through it. Just your straight leg Lazaigs test, your straight leg raise with added dorsiflexion, and testing for higher up, much less common, but your femoral nerve pain, prone bend. Just see if we get the symptoms, and we do that. Treatment for lumbar spine, right? An interesting thing. Oh, here's a lovely picture. This is somebody having their lumbar spine treated in the Sidi Physio Clinic. I don't know where Asa got that from, but anyway, it says analgesic medication. Right. Big problem with what's happening. Back pain, statistics show it's actually increasing all the time. But at the same time, there is so much more opioid prescription being given. And this is about the worst thing we can have. The best thing is get them paracetamol. There's a lot of these surveys being shown that people are actually not taking the correct dosage of paracetamol. They probably need more. But once you start, and NSAIDs as well will help a little bit. There's a bit of a few ideas that maybe the NSAIDs aren't so good, but the paracetamol will help. Once we start getting on the opioids, we have a massive problem, because this is where we start getting the chronic patients. We're getting the central nervous system sensitized to such a level that any pain which is coming in saying 2 out of 10 is reaching the central nervous system. Central nervous system is saying, whoa, 10 out of 10, and they send the inhibitory messages back, which puts everything into a spasm. Generally, a lot of these fibers are orientating up and down. They'll constrict. We'll get extra pressure on the spine. It's just a terrible, terrible ongoing circle. With opioids, they also kill you. So just try and get your patients off those. If they've been on for a while, we've got to wean them off. Active range of movement exercises. This is the important stuff. Range of movement, strengthening exercises, stretching, and the MLS, the laser, which will reduce the inflammation, reduce pain, and then allow them to do more of the movement, more of the strengthening, more of the active range of movement, more of the stretching, because this is what makes you better. It's none of the surgery, no. Opioids, no. It's active movement. And people going into this chronic situation where they're into avoidance is the problem. When we're doing the laser, we can move people into better movements. We talk about the optical window. Try and open up the area which is the problem. So we can here we've got the person opening up the left-hand side. Well, opening up both sides actually. We can actually get treating on there and try and get the laser right in that intervertebral foramen. Right, I think that's it. Yeah, the references. Right, so let's come back to the real world. Negative beliefs about low back pain. It's a massive problem. Practitioners, we have a bit of a problem as well, because we sometimes go, oh, this is very bad. Yeah, you've got a herniated disc which is putting pressure on that nerve root, and people start thinking, oh God, I'm broken. let's tell them the truth, exactly what the condition is, but let's be totally positive about it. So just a bit of practitioner education, it can positively influence the beliefs of these patients and manage their behaviors. Right, what is a radiculopathy? The strict definition: localized displacement of disc material beyond the normal margins of the invertebral disc space, resulting in pain, weakness, or numbness in a myotomal or dermatomal distribution. Right, very, very simple. It's just we've got pressure on that nerve root. Presentations, we talked about pain, weakness, or numbness in the myotomal or dermatomal distribution, with or without low back pain. You can get some patients where the pain in the lower back is actually very, very slight, but that's where the problem is coming from. What's the difference between radiculopathy and sciatica? Nothing at all. Sciatica is, radiculopathy is saying we've got problems with the nerve root. Sciatica is a specific form of radiculopathy. What we mustn't get confused about now is pain down the back of the legs. That is not necessarily a sciatica. The patient always comes to me, says, I've got sciatica. And I find out they've got nothing wrong, no sciatica at all. Could be a piriformis syndrome, which is pressure on the sciatic nerve, but not from the nerve root. It's not a radiculopathy. You can also get pain down the back of the legs, which GPs send down saying they've got sciatica. No, they haven't. They've got real problems with trigger points in the probably the glute minimus is the big one, which can send pain down the back of the leg, right down to the ankle, down the back or down the side of the leg. So you've got all these trigger points which we've got to look out for as well. With a radiculopathy, certain things we know, probably around about L4, if there's a problem at L4, we'll probably be getting some pain in the shin, medial side of the shin. You'll find more with L5 pain on the inside of the foot, S1 pain on the outside of the foot. This is where you're really going to get pain at the end of the lower limb. Okay. Right, I've got to put a little note here, pharmacology for radiculopathy. Opioids, we just don't use them. The side effects are massive, and it can lead to addiction very, very quickly. And it just sensitizes the central nervous system, sensitive nervous system so much that we're getting an incorrect message system going on. Pain 2 out of 10, 10 out of 10, inhibitory messages coming back, big problem. And the other big problem for opioids is death, and because they'll kill you. Right, now, this is the next thing I want to talk about very quickly. What is pain? The International, I'm just going to look at it, the International Association for the Study of Pain, 1986, long time ago, but this has not changed. It describes pain as, and this is so important what we're going to talk about here. Pain is an unpleasant sensory and emotional experience. I'm going to stop there straight away. Sensory and emotional experience. This is so vital in a radiculopathy, associated with actual or potential tissue damage or described in terms of such damage. Sensory or emotional, okay? Right, now I just want to talk very briefly about what I used to do. I used to work with the military for a long time. I used to run the regional rehabilitation unit in Aldershot. There's 3 big RAUs, well there's 4 because Headley Court was counted as one as well, but that's now up in Birmingham. At the garrison towns, the RAUs, regional rehabilitation units, we would actually take in the patients from right around all the camps everywhere around the British Isles who've had problems, they're having their treatments in their PCRFs, they're not getting any better, and we're getting an awful lot of chronic problems. They're sent down because this is the end of the world for them. So they come down to us with a sports exercise medicine doctor and the physiotherapist. We do a massive clinical examination, make a decision. Do they need surgery? Do they need further scanning, MRIs? We try and stay clear of that as much as possible because we go on clinical diagnosis. Or the third option used to be either the 3 weeks spines course or 3 weeks lower limbs course. Okay, what is that? For 3 weeks, we'd have them inpatient from 8 in the morning till 3:30 in the afternoon. They are doing a full day with a half an hour break for lunch, a full day of exercise, physiotherapy, and lectures. We educate these people, and the education thing, along with the exercise, as far as I'm concerned, is the most important thing. The physiotherapy, in a way, is a bit of trying to make them feel a bit better and cared for. But it's getting this stuff done so important. Why? Because these people are coming in, they are broken. They're in this psychosocial situation whereby they are catastrophizing. They're military people. They're not really trained to do anything else. That is their job. They've got this back pain. It's been going on now for 3 years. They've got a problem. They've had all this treatment with the PCRF. Nothing's got better. Why? Now, well, that's another thing. But the problem is they have become mentally blocked. They have become depressed. Posture changes, range of movement changes and everything. They're not doing the exercises because if they do the exercise, it's going to hurt them. If it hurts them, that means tissue damage. No, it doesn't. On the contrary, it's completely, what we need to do is get the exercise going. So they have all these psychosocial problems going on, and our job is to actually pull them out of the tunnel, put them on the edge and say, right now, this is the course. You've seen what we can do in 3 weeks. How do we do it? Always remember, when you're doing physiotherapy at any level of anything you're doing, objective measures are just so important because we want to reinforce the beliefs with the patient that they are getting better, show them that the treatment is working, and this has a miraculous effect. Now, what we do is the first day of that 3 week course, we have a whole day of validated objective measures, which takes a whole day to put them all through. And we take all the scores, very strictly written down, very carefully organized. Then there's the 3 weeks of exercise, of physiotherapy, of lectures, teaching them about chronic pain, teaching them about the problems that they've got, teaching them about anatomy. All these things, which we can't really do in the social world, but we can actually give people a quick overview. We do that for 3 weeks. 2 days before the end of the course, we do all the objective measures again. And on the final day, we call them in for an individual interview, and we sit down with them and we say, that is your score at the start when you came in, and 3 weeks, this is your score now. And the graph was always like this. Right up, like you can't believe. And it gets these people in a situation whereby they are able to manage, they're able to cope, they manage. One of the things we tell them in the lectures was, if it was a real chronic problem, we said we probably can't actually get rid of your pain 100%, but what we can do is we can put you in a situation where you can manage this and take it forward. We focus on other things. We don't focus on the pain. We don't fear the pain because the way to get rid of the pain is the exercise. Now, I hope you don't think I've digressed too much, but this is so important with the radiculopathy. It's vital we get this going. There's all sorts of psychological screening you can do. There's loads of depression, anxiety, stress scales, fear and avoidance scales, all these things you can do. But don't forget, the psychosocial aspect with somebody with radicular pain is incredibly important. Okay, when you're doing your objective measures, your objective examination, screening questions are very important, essential for actually working out. Also, that's more on the subjective. Do they have psychosocial problems? But when you're doing the objective stuff, really the body chart is very important as well. It tells us an awful lot. Anyway, going forward, I've made my point about this. Psychosocial, do not miss this. Very important. Right, I'm going to get straight into treating this patient. I want to show you something which I think is quite important. I'll come back and set up the laser in a minute, but if we can get the patient over here. Right, here's the patient. We're not just up in PPE because the patient happens to be my wife. And so we're in close contact, so don't nobody write in to the BBC saying they watched a webinar where somebody wasn't wearing PPE. Right, we've done subjective, we've done basically objective. We see problems in the movement of the back, everything like that. We find out we've got pain coming down her left hand, leg, everything, all this problem. I'm going to check the dermatomes and the myotomes. I told you about the myotomal stuff. Can you just sit down, sit up here? I would have their socks off. Okay. Remember what I talked about? 3, 4, 5 down here. S1. That's the thing. It's not the most. It's not the best. Right about dermatomes are not the best thing. Myotomes, we all know, are other stuff on the higher up. But we're talking about L4, 5, S1. That's where 9% of the stuff happens. Okay. Just very simple. L4. It's the muscles which are causing inversion. So bring your foot in that. Okay, just boom. Okay, right, that's pretty good. Bring your big toe up. L5, can bring your toe up right there. I think she might have an L5 really. It's just weaken the big toe. But L5 is big toe extension, L5. Bring your foot out like that, okay? S1, right, always look for that area. Weakness coming out here is telling us S1. This is going to tell us where to really go with the laser when we get it going. That is L4, 5, S1 on your myotomes. Right, reflexes. Well, we all know about L4 up here. Okay, and we'll go, okay, lovely reflex. 6 of these, nice and brisk. Okay, and we all know about, just relax that please. We all know about S1, beautiful, okay, fantastic reflex, okay. Now, what we don't know about is L5. Very few, I can see a few people there. Put your hand up if you know about how to test the reflex for L5. Do we have a hand? I can't see a hand. Brilliant. L5, so easy. Medial hamstrings. Get your finger on here. Okay, and then. Okay. Just relax completely. Okay, well, we're getting a little bit of activity here. It's not that strong, but that's how you test your L5. Medial hamstring. Oh, beautiful. That's a, yeah, she has a bit of a slight reduction on the right hand side. It's the left hand side we're going to treat. So right, that is topic. Let's say we've got L5. L5, let's say it was a problem. It was completely absent. And L5, I'm going to go with what we've got here, but it's not true because I know it's not a myotomal thing. But we had weakness in the extension and the hamstring's not so great. And I'm going to do it on the right leg. This is L5. Right, so let's turn you over. What we will have gone through with these people, she'll have probably had most likely coming, real problems in the back coming forward. It's telling me that we've got compression on the front of the disc. We need to actually just take the pressure off the back. Now, the most important thing, the person rings me up, I've got terrible pain, I don't want to see you for 48 hours or 72 hours. Just get on with doing your Mackenzie extensions, okay? We all know Mackenzie extensions, there's all sorts of stuff, but we want to get them doing something. Mackenzie extensions, can you get your just, no, let yourself down, right down, okay? And make sure the muscles here, very important, the muscles don't come in here, push up on there, very good. Stop this, okay? Okay, come up higher, okay, and slowly let yourself down on your arms, the muscles are not coming in, okay, boom. Right, Mackenzie extensions, 10, 15 of those, 15 times a day, just get doing it. What we're doing here, you might think, oh, if the bulge is out the back, we're making it worse. No, we're not, we're taking the pressure off the front of the disc, which is allowing it just to smooth back into place as it should be, okay? So that's what we're doing there. Right, okay, you can see, yeah, you can see me fine here. God, not that time. Right, L5. I'm going to bring this down a little. Is that all right? So I should ask the patient first. Can I bring this down a bit? Yes. Okay. We've checked in here, bad trigger points in glute minimus, which is also probably causing some further, more widespread pain down the leg. But we're getting to radicular pain, lancing pain all down the leg, which peripheralizes, centralizes, and it's causing some pain more down the dorsum of the foot, with L5. It's saying L5. Everything says L5. Right, we're getting here. L4, L4, L5. We get on here. Essentially, a little bit of pain. We go on to the right, L5, S1. What's that like? Shout terrible. Terrible. Okay, and we're saying there's some pain down there. Okay, so what we've got, L5, we know exactly where we've got to be. Okay, right, now, we're supposed to be at the laser, and I've talked all about everything else. If you can wait there, Francis. But I think it's incredibly important to actually go through what we've gone through, especially that psychosocial element, because we've got to get it, the patient has to be educated. Movement is so important. Outcomes will improve if we can get you going. Be positive about it. Do not fear movement. If you fear movement, you might as well, I don't know, give up. We don't do that. Right, L5, we know where we're going to go there. Let's go on to our laser, okay? Now remember, L5, we've got a huge amount of inflammation of that nerve root coming out there. We've got to try and reduce that. Just before I go on to the cellular laser, if you've just got the handpiece, there is the one thing which ASA always recommend, the global approach and then the pathology element, okay? Now the global approach means we're going to scan all the tissues. With the Charlie head, I could actually probably do that at the same time while I'm treating the pathology, but we'll show you both, okay? Right, so let's get on to the, we'll start, right, hopefully you can see the screen there. We're going to get straight on to just treating with the handset first. Okay, right, here we are. Right, we've got problems here, down L5. Okay, so let's press on that. Just to let you know, in a much more acute situation, you'll generally find that the hertz are slightly lower and they're increased if we've got more chronic, okay? We'll leave this as, this is a fairly new problem. It just happened, I know, last week, and she's managed to get to see the physio, and we're going to sort this out now. So we're going to say it's pretty acute, okay? So it's got all these different pathologies here, but we're not going to mess around with any of that at the moment, because what we're going to do is, oh, that's on 2, here. Lower back. Now that's to do with, if you're doing the Charlie head, I'm on the handpiece. If you've just got the handpiece, you won't get this. This is to change between the Charlie head and the handpiece, okay? So you won't have that, okay? But I'm on the wand here. I'm not going to go into the pathologies. I'm going to do the scan first. So I'm going to press scan. When it comes up acute, you probably see the hertz are going to change. If I go chronic, it's going to go up a bit, and the intensity will go up. But in the acute, it keeps it down, okay? Fairly low. It's a very acute situation, this. So I'm going to leave it there. I'm not going to change this in any way. I'm quite happy with that. And what I'm going to do is I'm going to press start. But before I press start, how many, if you've seen any of my sessions before, what's the first thing I do? I stick on the glasses. Okay, so I give glasses to the patient. And glasses to me. Right, so we can see this.
I just ask Paul, as you go in, can you use the Charlie head and the handpiece together? And would you use the head for an area and a handpiece for another?
Absolutely. We can use them both together, and it will save us time as well, or we can do different pathologies because we can have completely different settings. I just want to show people, because most of you will probably just have the handset. Let me just show you. You can probably see my handset there. If I press start now, okay, you probably see it just flashes 4 times, okay? It's just not going yet, but it just flashes, tell you there. And what we're going to do is we're going to scan around all the areas which really need to be scanned around. Okay, so that's me moving this way. Which side did you say was the bad one? Right. The right, okay. So I'll probably scan just down. I wouldn't have my patient with shorts on. I'd probably get them down to the rest so I can actually get into the glutes as well. And we get to cover all this area. But I'm going to scan probably from about L3, but really over the quadratus lumborum, big time, over the spine itself and over the quadratus lumborum, up and down, and across. And I come down here. Unfortunately, we've got the shorts on, but I'd probably be going on the skin over here. Miss the underpants for that, and coming down here, boom, if you get the idea what I'm talking about here, and then coming down where the sciatic nerve comes. So we scan throughout here. Now, I can't remember what it said, it was probably 4 minutes. We're probably going to scan 4 minutes. You can probably say, oh, maybe it reasonably quickly. In the more acute situation, we do generally move this a little bit quicker. In the more chronic situation, we'll probably move slower. Okay, we'll come back here.
And do you just scan the affected side, Paul?
I am at the moment, but I probably would, because there's 4 minutes, I'd probably give it a little bit on the other side as well, just to loosen up all the tissues around here. I would only go on the leg down the affected side, but I would actually also work on the quadratus lumborum and the spine, both sides. Okay, so we go on 4 minutes right across, going lovely photo modulated light into this tissue, start a bit of ATP creation. Oxygenate all the tissues, get a bit of blood flowing in here, and back down here, okay? Right, I'm going to stop it there, but it will just go on until it's finished, and it will just stop itself. The noise you will hear when it stops itself is right, do it like that, and it stops itself. So we've done that. And then, let me get back to my, my screen here. Right, so we've done the scan and it stopped. Okay, go back. Right, let's deal with the problem. We've got this problem at L5, sciatic pain. Okay, now it's a general guidance. It's giving you all these points in the back and one down in the leg. I know, because I've just done my clinical examination, I know we are talking L5 here. I'm going to concentrate much more around that area up here. What it's saying is, it's saying 10 minutes, 100% intensity, 900 hertz, 14 points. Okay? Now, you can actually, if it's acute, you can probably leave it on there. If it's much more chronic, we could probably go up a little bit. We go up at 901. It's going to take you forever. Okay, so let's go 1000. Okay, now you'll see my joules per square centimeter have actually come up. Okay, if 100%, I can't go more than that. That's 100% intensity. 14 points. That's what we're going to do. There's 10 minutes of this. We're not going to do it all, but let me just show you. If it's 10 minutes, 14 points, it's going to be about, what, 40 seconds each point, and it will stop itself. So we'll just show you a couple of points. And we know we're talking about L5. I press start, and let's go back to the patient. Right, there's the patient. Right. Now I've got 14 points, and I'm just going to go around here. 40 points. It talks about 6 up here and 1 there. We're going to obviously do everything twice, but hopefully you can see this. I'm coming here, 4, 5, and I'm pressing there. And that's a real, ow, shout out.
Ow.
Okay, right, there's a real problem here. Okay, let's start on here. Bang, I got it on there, and I've just got it, I don't know if you can see, but I've got it on that, around that area. Okay, and I'm going to do points just really very close around this area. Okay, now I'm obviously missing something here because there will be huge amounts of trigger points in the quadratus lumborum and probably in the glute minimus and medius, and we'll look at those afterwards. But while we do this pathology, we just get it on this area and we leave it there. We don't move it, we don't, and no pressure, it's just working on there. And I'll bring the camera a little bit closer so you can see. It stops itself. It just stops it automatically. And what it will say on the screen, it will have gone from 14 to 13. And it will be counting down the minutes and counting up the joules. So we started in there. I'm just going to go a little bit below it, okay? And hopefully you can see it's working in this area here, okay? So basically, I just leave that. I do not move it. I leave it there. And then we'll get the 6 points around here, and I'll move on to some areas, an area just down here, which is particularly bad. Just to show you what we're going to do is the 6 points around here. I'm going to move it because I'm going to probably round right here, but all around the L5 region, okay, and I'll probably go a little bit on the other side across here, probably come on there, but I'm going to just be working around here. Don't move it like that, you keep it in that space all the time. It stopped itself, and I'm going to move up to here, just above it. Okay? And it will stop itself in another 40 seconds. So let's say 40 seconds post pass, it just says stop, okay. I'm going to get onto here. Okay. And I do, I'm getting on here as well. Right now, the first session we ever do, I probably don't do too much movement because they're really tender, really bit of a problem. But do you know what? Actually, in a lumbar radiculopathy like this, I would probably start some active movement straight away. And the active movement I will be getting was, if I just move, I'm going to take this off here, I'm going to go back to where I was here, around the L5. And I'm going to say to the patient, see, it stopped itself, I'm going to start it again. Okay, right. Remember those Mackenzie extensions I taught you? Okay, right, can we start doing them now? Right, right, down, 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 down. I don't want this active, okay? I don't want anything, that's it, beautiful, okay? And then down. So I'm getting some active movement. So what the patient is doing now, come on, keep on going. Keep on going, that's brilliant, okay? So we're getting some active movement in here at the same time. Right, now, I'm just going to stop it because what we're doing, this is the first time, I'm going to go doing some Mackenzies. Where we can actually get some further movement going is, let's pretend it's worse on this side. Turn onto your right-hand side. Okay, that's the second treatment, third treatment, whatever. They're coming in. Let's get the optical window. Let's open it up a bit. So just so there, I'm going to get them in what would be a manipulation position. So just you relax completely. Relax. Switch that knee up. Switch this now. Okay. Right. So pull it there. Whoa. Nice little bit of movement now. I'm going to get this over here. And I'm just going to move them over here a bit. Twist them around. Okay. And now we've got this lovely movement. We're opening up L5 massively here. And this is just you relax. Just relax. Okay. Okay. And we're going to. Right, okay. And we're going in here now. So we've opened up the optical window and we're really getting into the area that we want to. Okay, it stops, carry on as so on. Unfortunately, I've had to say it's a different side, but now what we do is, so we're doing in here and it stops again, let's say, boom, and then let's get onto the leg in this area, boom. And here, we just try and take it out of it. So it's Just putting a little bit of stretch. If it causes any problems, just bring it back. We don't want any problems, okay? And then get it going again there. Okay, so just seeing what the patient is like and getting what movement we can out of them. Right, I'm going to stop that, okay? Exactly the same if we're using just the Charlie head. We could use just the Charlie head, but in fact, I tell you what, we've got static setting on the Charlie head as well. But what I'm going to do is, because we are running out of time, I'm going to actually show you how we'd use them both at the same time. Because what happened there, we've got 10 minutes for the pathology and 4 minutes for the 4 minutes for the scan, which we did beforehand. What we can be doing is getting really reducing muscle tension in this area and in the legs while we actually just come to the pathology. So if you go back onto your front, just so it's a bit easier, we can do it in the sideline, or we can do it a sideline, or we can do it prone. Let's get back to this. Right, now if you've got the Charlie head, you can probably see what this has been doing is the 6 minutes 45 left, 10 points left, and it's just counting down till it finishes. And I go diddly and all finished, okay? I'm stopping all that. Okay, we've got the situation. Right, we've decided what we're going to do is, we're going to do with the handset, we're going to do the static pain. So we're going to get straight on with this as we did before, and we're not going to change the settings. It's all beautiful. Start. Remember, it flashes 4 times, but it's not going until we press the button. Right, now what I'm going to do now is I'm going to press this little sign here and go to the Charlie head. Right, now what I'm going to do with the Charlie head is I'm going to actually use a setting for muscle contraction, because we've got all these areas where there's trigger points where muscles are so tight around there, and we've got to loosen it all off. Okay, which will be doing what the scan was. I'm going to go on the muscle contraction, 700 hertz, 5 minutes, 50%, 1 point. Okay, it's just giving you 1 point. What I'm going to do is I'm going to go 5 minutes in this side, 5 minutes on that side, probably 5 minutes, or probably 3 minutes, 3 minutes, 3 minutes. Okay, that'll make 9 minutes. That'll be 10 minutes. Okay, so that's what we're going to do. That'll be perfect. So what I'm going to do here, muscle contraction. I'm just going to change the 5 minutes to 3 minutes. 3. So we're on 3 minutes. But what I'm going to do is, I might just say, when it's acute, we'll leave it at 50%. I'm just going to go now 3 points, okay? Because now I'm going to cover everywhere. And I'm going to start that. Again, the big head will flash 3 times, but you'll see it's not going to start. What we're going to do is, we're going to move back to my other screen. Right on there. Okay, there's my Charlie head. Okay, got massive tightness both sides in here. I'll bring that down a bit. What we do is, let's get the Charlie head in the right place. It will be that distance. I can't remember what they are. I think it's 20 centimeters, but that's the distance it will be. There is a metal piece which you can use, but don't do that because it sticks in people. 20 centimeters, that's perfect. So I'm going to leave that there. And I just press the button on the top, and you'll see, you've got your specs on, haven't you? That is just going now, causing decrease of muscle contraction all over that area. At the same time as I'm now going to go into the point, which is a real problem just here. Okay, and I've got that going. You can probably see that's going as well. Okay, and I've got that on the point. I'm going to do my 14 points. This is going. After 3 minutes, this will stop. Okay, all I have to do is just pull it over to here and get that going there. And I've got this will stop when it's ready, and so on. But so it stops now. Just move to around there. Okay, and let's say another 3 minutes has gone. This one stops. Okay, what I'm going to do now, we said the left leg now is the problem, yeah? We're going to get this on here. Okay, can you still, I'm going to get that, so that's a bit too far away, go bring it down there. Perfect, okay, and that's stopped again. We're going to get back in here. I've got the whole thing done in 10 minutes, everything, and they will be feeling improved from this. We can still do our active movement, so get your Mackenzie extensions going. Then the switch, go down, switch is off. Do not let this come on. Okay. No, down. I don't know what's happened to you. Okay, come on. Okay, that's better. Okay, brilliant. Marvelous. And so on. Until we're finished. When it finishes, it'll go diddle it, stop. This will go diddle it, stop, and look, stop itself there. Okay, and we'll say that's diddle it, and that's stop. Right, we're finished. Okay, now luckily we're going to have 4 minutes. 4 minutes for questions.
Thank you.
Right, let me get the light back on.
We've got 2 or 3 questions, so yeah.
Well, we've got loads. As I say, we can use that Charlie head for a completely different pathology if we wanted. We can use it because it's all independent settings. And as I showed you there, sorry, let me get the screen back on me. What I showed you there was we did an independent setting for muscle contraction on the back. I could have done that for neck pain. I could be treating neck pain. I could be doing anything I want. And I'm doing the sciatica on the with the handpiece. You can do anything you want. It's phenomenal. This there is so much you can do it at the same time. And the thing which I have mentioned a couple of times in this present day of distancing, etc., like that, and some people might not want to be like the physical contact of a lot of the treatments we do. But you can actually do the treatment at a 2 meter distance, certainly 1.5 meter distance, by just having the Charlie head over them and you're not touching them at all. And so any patients who are a bit nervous or anything like that, it's a fantastic way to treat them as well. Right, so I'll shut up. Any questions?
Well, actually, I think you've answered Sam's question, but just to clarify, so you can use the Charlie head for L5, then the handpiece for the glutes and ham at the same time. So the idea of the Charlie head and the handpiece is you can have them on 2 different settings. That's right, isn't it?
Completely different. I could have done the sciatic setting on the Charlie head on the back. It will probably just have probably says 6 points. You 3 points in the back and 1 in the leg. Sorry, 2 in the back, 1 in the leg, and you repeat that twice. Okay. Yeah. But it'll be the same time.
So they're running independently. Yeah. I think that's Sam's question. So thank you. Just come back to me, Sam, if that doesn't answer it. Is it necessary to treat the non-affected side? Do you do that typically?
What I haven't had time to show you is the trigger points setting. Yes, I would always treat that just a little bit, because somebody with a radiculopathy, that is referring to the nerve root being compressed in that level, which we know, which we worked out clinically. But what's going on, as I said in the earlier slides, there is muscle contraction, there are trigger points, there's all sorts of stuff going on, and that's why we scan. And we scan to try and get some photobiomodulation through all the tissues to start loosening them, start getting ATP through them, start getting blood flowing through there. Yeah, there's so much. And that's why, at the end of the day, that's why exercise is the most important thing you can possibly do. Because these things get worse. If you stay still and don't move because you cannot move because it's hurting you, then things will just get worse. We have to get mobility going. We have to get flexibility moving. We have to get all these things going. The biggest problem we have is people in too much pain to do it. they're in so much pain, therefore they won't do it, because if they do it, obviously it's tissue damage. Well, it's not. But the point is, that's what they believe. If we can actually reduce the pain through using this machine, which it will do, it will reduce the inflammation, but the 905 nanometers is actually inhibiting pain pathways at the same time. So it has a phenomenal effect. If things feel easier, then you can get these people helping themselves. It's about the psychosocial thing in radiculopathy. I can't express how important it is. The military, we've got all the evidence. We can show you exactly what a difference it makes, okay? What the civilian world is different, because you can't make people do anything. But if you educate them enough and you teach them and you show them the improvements they're getting, then they'll start believing and they'll get involved. Their involvement is totally important.
Brilliant. Going back to the treatment, is it necessary to scan the psoas also, the psoas muscles? You know.
Well, your psoas, you're on that psoas area just on the back. It will be, we're trying to get into the nerve root. The psoas, as you know, the psoas is actually going to start from the lower lumbar four vertebra, okay, then comes through the body and then is the major hip flexor. So you're going to have some effect on it anyway, but we're not particularly going for the psoas, but it's not going to harm it in any way. I mean, once they start feeling a bit better, we can start doing, because they'll probably get very tight in their psoas, we can start doing some muscle energy techniques on the psoas, and which will make a massive difference as well. But just while we're going in on the L5, we're actually going very close to where those psoas is, more coming out from the facet joint, but that's what we're doing.